Hello everyone, hope you're all doing good. This is a video where I'm going to tell you about the various procedures done in gynecology, including your hysterectomy, laparoscopy, hysteroscopy, and even biopsies. Okay, so let's start about the procedures in gynecology. Okay, yes. Now, first let's talk about hysterectomy, which is surgical removal of the uterus. Okay, so the methods of doing hysterectomy will include abdominal hysterectomy, which is done to the abdominal root, then vaginal hysterectomy, which is done through the vaginal route, laparoscopic hysterectomy, and it can also be a laparoscopic assisted vaginal hysterectomy. Okay, where we will be cutting the uterus through the laparoscopic route and the specimen will be retrieved through the vaginal route. Clear? Now, let's see the type of hysterectomy and the structures removed here. Okay, so there are 6 types of hysterectomy I am going to discuss. First one is a total hysterectomy. Okay, where you will be removing the uterus and the cervix. Second one is a total hysterectomy that will be done with USO, that is unilateral salpingo-oophorectomy. So what you will do? You will remove uterus, cervix and either side of the adnexa. Okay, if there is any associated pathology with it. Okay, say a hydrosalpinx or an ovarian cyst or a tumor like that. Okay, so either it can be a right or left salpingo-oophorectomy. Okay, and the next type is total hysterectomy with bilateral salpingo-oophorectomy. So it is already understood, right? So you will be removing the uterus, cervix, and you will be removing the bilateral salpingo-oophorectomy. That is, you will be removing the bilateral tubes as well as the ovaries. And the next one is an extended hysterectomy, where you will do total abdominal hysterectomy with the bilateral salpingo-oophorectomy, and also you will remove the upper part of vagina. Upper part of vagina, that is extended hysterectomy. Okay, then we also have radical hysterectomy, where we will be removing the body, cervix, upper part of vagina, then parametrium, draining lymph nodes, like that. Okay, you can also have a supra-cervical hysterectomy. Okay, so supra-cervical hysterectomy means you will be removing only the body of uterus. Okay, that is supra-cervical hysterectomy. Okay, now let's discuss about the indications of doing hysterectomy. Okay, so indications of hysterectomy. This will include abnormal uterine bleeding, or a fibroid uterus, even in adenomyosis or endometriosis, and even in carcinomas, say an endometrial carcinoma or cervical intraepithelial neoplasia or cancer cervix. And hysterectomy may also be done as an emergency condition. Okay, so it can be required as an emergency condition also in certain conditions where there is uterine perforation or rupture uterus, post delivery also when there is atonic PPH or clear? Now let's discuss about the steps of hysterectomy. Okay, so steps of hysterectomy. First is position. You have to make them lie in a supine position. Then you have to do a catheterization. Catheterization will be done using a Foley's catheter. You will give mostly a spinal anesthesia. Okay. Now let's discuss about the incision. Okay. So incision we will give can be a transverse incision, that is nothing but a phalansteal incision, or a vertical incision, that is vertical means infra-umbilical midline incision, or even a paramedian incision. Okay. Now let's see how we will be proceeding after giving this incision. Okay, so the incision will be given in the skin, right? So after the skin, we'll be dissecting the subcutaneous tissues. Then we'll be reaching the rectus sheath. Then rectus muscles will be retracted. Following that, the extraperitoneal fascia will be cut. Then following that, the peritoneum will be opened. Okay, so what are the layers we have gone through? It is the skin, subcutaneous tissue, then the rectus sheath, then you will be retracting the rectus muscles, then you will be cutting the extraperitoneal fascia and you will be reaching the peritoneum. Okay. After this, thin layer of peritoneum will be held by 2 artery forceps and an incision will be given at the upper part. You have to exclude no bowel loop or any momentum while giving this incision. This is very important. Okay. After this, a small nick is made by scissors or scalpel, and then incision will be extended through the scissors and abdomen will be opened. Okay, and abdomen is opened. Clear? Now, after this, the margins are retracted by either using a self-retaining retractor or even a simple Doyen's retractor, and then you have to examine the pelvic organs, and then the fundus along with the 2 carnivora are held using clamps. Okay, you have to pack the bubble also from the operator field. Now let's see what are the clamps you have to apply in order to get a hysterectomy done. Okay, so it is clamps in order and what are the structures cut. Okay, so first clamp is going to be for the round ligaments. Okay. And if you see the second clamp, it depends whether you want to do a salpingo-oophorectomy or not. Okay, suppose if you want a salpingo-oophorectomy, then you will cut the infundibulopelvic ligaments. Okay, and suppose if you don't want to do salpingo-oophorectomy, then you will be preserving the tubes under the ovaries, and the structures that will be removed will include broad ligament, including the ovarian ligament and mesosalpinx. In case of cutting infundibulopelvic ligament, these structures will include the tubes as well as the ovaries. Clear? Now, so this 1 and 2, clamping, cutting and ligating, okay, will be repeated on the other side also. Okay. And after this, one important step is there. You have to cut the UV fold of peritoneum. Okay. Now let's discuss the next step. So it is step 3, that is clamp 3 actually, where you are going to transect and skeletonize the uterine vessels. Okay, actually you are going to skeletonize the vessels. Okay, that means removing the tissue that is surrounding the vessel. Okay, so that will minimize the vessel retraction, that's why. And it is usually done at the level of isthmus, and vessels are cut vertically here. So the clamps will be put horizontally. Clear? Now coming to the fourth important clamp. This is done for the Meckenroder's ligament. Okay. So this will be put below and medial to the uterine pedicle. Multiple clamps may be needed. Then it depends upon the length of the ligament. So how much you have to clamp, how many clamps you have to put. Okay. And in the last clamp, we will also include the uterosacral ligaments. Okay. Then the same procedure will be repeated on the other side as well. Now coming to the next one, that is transection of vagina. Here we have to put curved clamps below vagina, below the vagina, and it will be put on both sides. Okay. Remember, the tips of the clamps should be in midline. Then some cases may need flared mobilization as well. Then the inferior level of cervix is identified by palpating the anterior and posterior vaginal walls. Okay. Then finally, the tissues, that is the vaginal tissues above the clamp are cut and the angles are sutured. Clear? Right. Now after this, we have to do closure of vaginal curve. So that is one important thing, where it will be sutured with 1-0 delayed absorbable suture. Usually we will be giving running sutures. Hemostasis will be secured and mechanorodent ligaments will be fixed with the lateral angle of the vault. Why we do this? To prevent prolapse, vaginal or vault prolapse. Okay? Yes. Then uterosacral ligament will be fixed with the vaginal vaults. Okay? Then you have to check if complete hemostasis is occurred. Don't forget to remove the packs you kept, and then the abdomen will be closed in layers. Abdomen closed in layers. Clear? Now let's repeat the procedure of hysterectomy with these pictures so that it will be helping you to retain the steps well. Okay? Yes. So this is the first step, where the uterus is elevated by using clamps that are placed across the leaves of the broad ligament. Okay? And in the next step, what we are going to do is round ligament transaction. So the round ligament is transacted. Okay? So here you are seeing the round ligament is cut, then it is ligated as well. Okay? And the next step is where we are going to do identification of ureter in the retroperitoneal space. Okay, especially in the medial half of the broad ligament. Okay, so you are able to see this, right? So this is how the ureter is going to run. Okay, so this is the ureter. So here also you are able to see the ureter. So what is the mnemonic you will keep here? It is water under the bridge. The bridge here is uterine artery. Water is the ureter. Okay, so this relationship should be known. That is very important. Okay, and the next step is ligation of utero-ovarian ligament. Okay. So here I already told you, if ovaries are to be removed, then the peritoneal will be enlarged and it will be extended kephalot to the ovarian vessel, so that it will be including the infundibulopelvic ligament. Okay. So this will be extended kephalot to ovarian vessels and caudal to uterine artery. Okay. So when you do this opening, so that will allow you better exposure. Okay, better exposure to see the uterine vessels and the ureter. Okay. Then we'll be doing ligation of the infundibulopelvic ligament. Okay. Then after ligating infundibulopelvic ligament, we are going to have a transection of the infundibulopelvic ligament also. Okay, so this is the infundibulopelvic ligament that is cut here. Clear? Right. Next one is, yes, ligation of uterine blood vessels. Okay, so here you are able to see the uterine blood vessels that are running across the lateral wall of the uterus. So that will be ligated and cut. Okay, and finally we will be putting incision of the recto-uterine peritoneum as well, and we will be doing mobilization of rectum. So mobilization of rectum will be done from posterior cervix. Okay, as well as mobilization of bladder can also be needed. Then we will be doing the removal of uterus by transection of vagina. Okay, so this is how the vagina will be transected and it will be removed. And then vaginal cup suturing will be done. Clear? Yes. Now let's discuss about the complications of hysterectomy. So operative complications can include hemorrhage, or there can be injury to bladder, ureters, intestines as well as rectum, and there can also be anesthesia related complications. Okay, and then immediate post-op complications. Here also there can be hemorrhage, there can be infection that can result in peritonitis. It can be urinary infection also. Sometimes urinary retention also will happen. Pneumonia is also an immediate post-operative complication. Thromboembolism. It can also lead to vault granuloma, so that can result in secondary hemorrhage after surgery. There can be wound infection which can lead to wound sepsis, or there can be chances of burst abdomen, abdominal distension, and paralytic ileus is also possible, which can present with intestinal obstruction as well. Okay. Clear? Right. Now let's see the long-term complications. As I have told you, there can be chances of vault prolapse, even incisional hernia, or even band adhesions. Clear? Yes. Now let me talk about vaginal hysterectomy also. So vaginal hysterectomy, you can give anesthesia that may be spinal or epidural or even general anesthesia. You have to put an inverted T-shaped incision on the anterior vaginal wall. Then the anterior vaginal wall will be reflected. After this, bladder is pushed up and incision that is made on the anterior vaginal wall will be extended posteriorly, and then the posterior vaginal wall will be reflected as well. Okay. After reflecting the posterior vaginal wall, the pouch of Douglas will be opened and the uterus will be delivered anteriorly, okay, by opening the utero-vesical fold of peritoneum, and the uterus will be removed by clamping, cutting and ligating the ligaments just in the inverse order what we have seen in total abdominal hysterectomy. Okay, so the ligaments will be cut from the down now, starting from the uterosacral ligaments, and it will be going up to the round ligaments, and that makes a if needed. Clear? Yes. So what is this? This is a cervical punch biopsy. Repeating once again. So next one we are going to talk about cervical punch biopsy. So this is actually how a cervix is visualized and a cervical punch biopsy is taken. So this is a punch biopsy forceps. Clear? Yes. Now this is usually performed as a outpatient procedure under strict aseptic conditions. Then for this condition, no anesthesia is required. Okay, anesthesia may be required when pap smear is abnormal, okay, or the biopsy is taken. In this case, repeating, in this case the biopsy is taken from abnormal area that is seen in via and villi. Okay, when there is cervical growth, or there is a erosion or an ulcer. Okay, so this will be the areas of abnormality, or when you suspect cervical malignancy. Okay, so suppose when ulcer is present means the punch biopsy should be taken from the margin of ulcer that will be including the normal area. Okay, that will include the normal area, and it will not be taken from the center of the ulcer. Okay, so these are the things you have to know about punch biopsy. Now let us see how a biopsy will be taken. What are the steps you have to do? Okay, number 1, the patient will be in dorsal position, and this should be done under strict aseptic precautions. A sim speculum will be inserted to depress the posterior vaginal wall. Okay, then the cervix will be held by using a valcellum. Then a punch biopsy forceps will be introduced, and biopsy will be taken from that specific area. Then it will be sent for histopathological examination, and finally you have to pack the vagina with roller gauze to prevent bleeding for some time. Okay, so these are the steps of cervical punch biopsy. Clear? Now let's discuss about dilatation and curettage. Okay, so dilatation and curettage. It is also performed under suitable anesthesia. The patient will be in lithotomy position. You have to clean the perineal area, inner thigh and vagina as well. Catheterization of the bladder will be done, and after this, please perform an on-table pervaginal examination. After this, you will insert some speculum to retract the posterior vaginal wall. Then, cervix will be held with valcellum. You will introduce the uterine sound through the cervical os to measure the length of the uterus. Cervical os can be dilated up to 12 to 14 millimeter with dilators, Heger's dilators or a Matthew Duncan dilator. So many dilators are there. Okay, so dilatation will be done. And finally, you will introduce the uterine curette into the cavity, and the cavity will be curated on all the walls of the endometrium from up to downwards. Clear? Yes. Right. Next one is, yes. Tell me what these instruments are. Next, what procedure we are going to discuss? Yes, it is going to be a hysteroscopy. Okay, so this is a hysteroscope. Hysteroscopy we are going to discuss. So, a hysteroscope is an instrument which will be introduced into the vagina to view the internal genital organs, especially the endometrium, not the internal genital organ. Repeating. Hysteroscope is an instrument which will be introduced through the vagina, that is a natural orifice itself, and you will be able to visualize the endometrium and any pathology related to the endometrium. Okay, so this is how the hysteroscope will be introduced. And see, this is a hysteroscopic view where you are able to see a large polyp that is present in the endometrium. Clear? Now, basic instruments of hysteroscopy consists of an endoscope, sheaths. You also have an endoscopic camera, a light table and source, a monitor, as well as fluid distension media. Okay. So, if you see, hysteroscope are of various sizes and types. Okay. So, they can be rigid type or even flexible type. It got a telescope as well, that is of 0 degree or 30 degree with the outer sheath. Okay. This outer sheath will be 2 to 6 millimeter in diameter. So, we will have a telescope that will be making a 0 to 30 degree of angulation with the outer sheath. The outer sheath is 2 to 6 millimeter in diameter. Okay. Then this hysteroscope will be attached to the fiber optic and light cable. Outer sheath channels will enable the inflow and outflow of distension media, and it also has ports to insert the operative instrument. Okay, and then the distension media used is mostly glycine, that is 1.5%, which is most commonly used, and this is a hypotonic electrolyte free distension media. Okay. Then what will happen means fluids will be used for continuous irrigation to give a clear picture of both the mechanical and electrosurgical instruments. Okay. And during operative hysteroscopy, if you are doing an operative hysteroscopy, repeating, during an operative hysteroscopy, absorption of large volumes of distension fluids occurs that will be leading to serious complications that is arising from the significant fluid overload. Okay. And with this, the intrauterine pressures can rise up to more than 75 millimeter mercury, and this is possible when the duration of surgery increases as well. Okay, so we know hysteroscope is used for both diagnostic and therapeutic purposes. Okay, so what are the diagnostic indications of you doing a hysteroscopy? So the diagnostic indications will include AUB to find the cause of AUB, then postmenopausal bleeding, if there is infertility, or to rule out any uterine anomalies or what is the type of anomaly like that. Okay, and the therapeutic indications of doing a hysterectomy will include for a polypectomy, then you can do even myomectomy of a submucous fibroid, intrauterine adhesolysis in case of Asherman syndrome. You can even offer endometrial ablation, hysteroscopic metroplasty, and then tubal cannulation also can be done. Clear? Now, what are the complications we can expect with this? Complications can include cervical trauma or uterine perforation, infection, even vasovagal syncope, and due to the distension media, electrolyte abnormality can occur that will include hypernatremia, hypertension, pulmonary edema, and when procedure is prolonged, it can also lead to postoperative hypotension or even mental confusion. Okay, and especially when you use glycine, they can present with encephalopathy, and with the dextran, anaphylaxis reaction can be expected. Clear? Next procedure we are going to discuss is, yes, by seeing itself you would have known, right? So what is the procedure? This is laparoscopy. So laparoscopy is a minimally invasive procedure, right? So here a fiber optic instrument is inserted through the abdominal wall. Okay, so here we have fiber optic instrument that will be inserted into the abdominal wall to view the organs of the abdomen. Okay, and we will be able to obtain a small scale surgery with the help of creating pneumoperitoneum. Here, so we also have an insufflator here. Okay, that is will be using the insufflator through this Veress needle. So the first step in laparoscopy is introduction of this Veress needle, through which will be connecting the insufflator to create the pneumoperitoneum. Okay, so there are two important instruments in laparoscopy. One is Veress needle. I already told you this is used to inflate either air or carbon dioxide to create pneumoperitoneum through the umbilicus. Okay, then we'll be having camera equipment and light source, and another important thing is trocar. This is a trocar instrument. So this will permit access to intraperitoneal cavity, peritoneal cavity through which the other instruments can pass. Okay, it will help the other instrument to pass through. Okay, then for intestinal preparation, what you will do for laparoscopy? You can offer them a simple intestinal emptying for better viewing and prevention of injuries. Okay, and the patient is usually placed in a dorsolaparotomy position. Okay, so laparoscope is also one procedure where it is used as a diagnostic purpose. Laparoscopy is a procedure where it is used both as a diagnostic tool as well as for therapeutic purpose. Okay. Now, how to create pneumoperitoneum? Creating pneumoperitoneum. Abdominal wall will be grasped by forceps, or it can be even lifted by hands. Okay, and then we'll introduce the Verres needle into the umbilical area. The needle is inserted at an oblique angle towards the uterine fundus. Okay, so after creating pneumoperitoneum, there will be negative pressure, so that will allow the underlying structures to fall away. Okay, that will allow the underlying structures to fall away. Then, after making sure that the needle is in correct position, you can even increase the airflow up to 2.5 liters per minute till a pressure of 15 mm mercury is obtained. Clear? Now, how will be the view of the peritoneal cavity? Viewing the peritoneal cavity. The omentum, bowel and bifurcation of pelvic vessels should be evaluated before starting the procedure. Okay, so that will help to avoid injuries that will be caused by the introduction of Verres or procarneal also. Then the site of introduction of trocars should be verified by finger palpation and trans illumination of abdominal wall as well, to avoid the injury to epigastric arteries. Okay, so identified if there is any bleeding, that means epigastric arteries would have been injured. Okay, then we'll go to the forceps and scissors. Okay, so forceps and scissors will be used. So these can be of the disposable type or reusable type as well as they can be atraumatic or grasping forceps. Okay, then we will use telescope of different sizes and angles. Okay, telescope of different sizes and angles, they will help to visualize the peritoneal cavity. Okay, so this is how we will enter the laparoscopy, and we have seen the instruments used in laparoscopy also. Now let us discuss about the laparoscopic contraindications. So laparoscopy contraindications. When there is generalized peritonitis or hypovolemic shock, severe cardiac disease, hemoglobin that is less than 7 gram per deciliter, uterine size more than 12 weeks, and when they had multiple previous abdominal procedures, because the chance of having additions will be more. Okay, laparoscopy view will not be proper in that case if additions are present. Okay, and there will be no use in doing laparoscopy also, because in some cases there can be a need to open the abdomen, that is, it can be converted into laparotomy as well. Okay, then extreme body weight. Okay, now let's discuss about the patient risk factors that are contraindications, that will include obesity, increased age, and previous abdominal surgeries, as I told. Okay, anesthesia risk factors will include any heart disease or pulmonary disease, and it also depends upon the time since last oral intake. Okay, now we have some recent advances in laparoscopy as well. 3 innovations have been introduced in laparoscopy. One is the famous robotic surgery, we all know about this, right? Yes. Then it is nodes. Nodes means natural orifice transluminal surgery, and next is sills. Sills means single incision laparoscopic surgery. Single incision laparoscopic surgery means through a single incision itself will be introducing all the instruments, that is a camera, a scissor, a forceps, whatever it is. Okay, right. Then diagnostic tool. Purpose of laparoscopy is used in case of infertility. Will be able to find the status of the fallopian tube, whether it is mobile or not, like that. Okay, any adhesions are present. Okay, like that. Then we can even analyze the presence of ovarian cyst or tumors, any ectopic pregnancy diagnosis if needed, or even pelvic inflammatory disease, and also endometriosis. Okay, it also defines the site of the implant. Okay, site of implantation of the endometriosis and the presence of endometrioma, that is endometrial cyst in the ovary. Okay, then therapeutic purpose of laparoscopy, we can manage ovarian cyst by doing drainage of ovarian cyst, then ovarian drilling of the cortex and stroma in case of PCOD can be done. You can sometimes correct the ovarian torsion that has happened, and as a treatment of endometriosis by removal of the endometrial cyst and a cauterization of the endometrium also. Okay. Then for management of infertility, what you will do when you want to do adesolasis, you can use even myomectomy of fibroids or hysterectomy for any cause, and then management of PAD by drainage of the tubal abscess. Okay. So, all these are the therapeutic indications of laparoscopy. So, with this we will be completing this video. So, I have discussed in detail about the various procedures we do in gynecology. So, I hope this video would have helped you. Until we meet in the next video, keep going, happy learning, take care and bye bye.